All right. Well, I think it's 9:30, so we're probably going to get started now. So welcome everyone to the Washington State Telehealth Collaborative. My name is John Scott. I am the chair of the collaborative. So a little bit different format than we usually do. We usually have half you guys joining by Zoom and half in person, but things have changed quite a bit since our last meeting in Olympia. So if you are new to the collaborative, welcome. I want to first start with a little bit of introductions and ground rules. We just ask that you mute if you're on the phone or by video, and then if you're on the phone, you can hit *6 to unmute yourself, or if you're on Zoom, just go to the lower left-hand corner and hit the speaker icon to unmute yourself. We do have a public comment period at the end. So if you remember the public, we ask that you hold your comments and questions to the end of the meeting today. Certainly you can type questions in the chat box if you want to. So I think what we're going to do is start by taking attendance. Nicole, I'm just going to read the folks that I see. So we have Denny Lorden from Providence. We have Cheryl Huchala. Welcome, Cheryl, from Primera. Joelle Fathi, Washington State Nursing Association. Kathleen Damon from Swedish. Ray Hanley from LNI. And let's see here, Dr. Frank from Washington State Emergency Physicians and Confluence Health. I see Chad Gamelin from Virginia Mason. I see Cara Towell from University of Washington's Department of Psychiatry. Adam Romney from Davis Wright and Tremaine. Lori Wakashigi. And let's see here. I think what I'm going to do next is just call on anyone who I don't see. There might be on the phone. So do we have Senator Becker on the line? Okay, she might be joining later. What about Senator Cleveland? Okay, Representative Marcus Rocelli. Representative Schmick. Okay, what about Dr. Chris Cable from Kaiser Permanente? I don't know, Chris. Okay, Stephanie Callan from Multicare. I know Stephanie was going to try to join, but had some other meetings. Stephanie, are you on now? No? Okay, Corey Gillenwater from Camia Grove. Do we have Dr. Guff from Molina? What about Sheila Green-Shook? Okay. Dr. Ricardo Jimenez from CMAR.
Is that the...
Was that Dr. Jimenez? No? Okay. Dr. Jones? Dr. Jeff Jones? I just saw Mark Lowe pop in. Hi, Mark. Glad you could join us. We have Scott Kennedy from Olympic.
Hi, John.
Hi, Mark. Scott Kennedy, are you on the line? Okay. And yeah, I think, Nicole, did I miss anyone? Maybe Dr. Kie. I think Josh was attending on behalf of the Washington State Emergency Physicians, but Dr. Ryan Kie, if you're online, please say hi. Okay.
Yeah, I think that's everybody.
Okay, so great. So what we're going to do first is I'm going to share my screen and just let you know what our agenda is today. So let me do that. And we have some great resources. So can everyone see my screen here? I'll blow it up a little bit. So first thing we're going to do is go through the minutes from our last meeting, which actually is not November. It was in January down in Olympia. We'll briefly check in with Stafford Strong and Samir Junejo, to give us an update of some of the legislative action in the last couple of months. Then we'll hear from Chris Chen, who is Associate Medical Director at the Healthcare Authority, and then hear about some resources that are being available through Telehealth Response to COVID-19 Task Force. That's Dr. King and Dr. Marcus. Hear about some behavioral health response team items from Jim Vollendorf. And then we want to spend the majority of our time just kind of checking in with various organizations on how they've responded to the COVID-19 outbreak and some of the challenges. And I just wanted to point out some great resources here on the second page of the agenda that Nicole put together. So there's a lot of FAQs here from the Healthcare Authority. There's a lot of information on billing and policy. The Northwest Regional Telehealth Resource Center, or NRTRC, has a COVID-19 landing page that you can go to, and they also are offering office hours. So if you are a small entity and wanted to know kind of how you get started with telehealth, they offer at least 10 hours of technical assistance that's free. So that's great. There's some quick starts. And then this last page has some things that Jim and his team are going to talk about. So with that, I'm going to share my screen and go through the meeting that was in January. And I asked that members of the collaborative review this. And if there are any things that need to be changed, that you please point those out right now. We did talk about some of the bills that were moving through the legislature last time. We talked about the eye exam. Heard from Nick Shalago about that. And talked about payment parity. We'll get some evidence on the credentialing discussion. And a little bit more on eye exams. So can I get a motion to approve the minutes?
So moved.
Okay, thanks, Jeff. Jones, do we have a second?
A second.
Is that Denny? Okay. Any discussion or amendments to the minutes? Okay, well, hearing no discussion, can we get a vote? I'll say aye.
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 All opposed say nay. Okay, we'll take that as an approval, and we will move on to our next agenda item. That's going to be to hear from Stafford and Samir. Stafford, can we hear from you first, and then Samir on some of the things that happened in the legislature this term?
Yes, thank you, Dr. Scott. I can start out with the payment parity bill, which is probably attracting the most interest right now. The 5385 is the payment parity bill that did pass this last session. It didn't pass in 2019, but it did pass in 2020. This bill requires payment parity for telemedicine services. It requires that the services provided through telemedicine be reimbursed at the same rate for providers who have 10 or for groups that have 10 or less providers. For 11 or more provider groups, it allows a negotiated rate. It changes it in 3 different areas of law. A lot of questions came up about this provision given the COVID-19 outbreak. They wanted it to be implemented immediately. The bill, as it passed the legislature, mandates the parity portion of the bill for plans beginning January 2021, which is not overly helpful for our situation now. But I did want to update that the governor's order of 2029 waives the 2021 language. And so at least until April 24th, currently the payment parity language of that bill is effective. And just a quick note on governor's emergency power orders that he used, the governor can waive requirements of law. It's under an emergency order, and they'll be effective for 30 days. After 30 days, it requires the legislature's approval. When the legislature is not in session, the 4 leaders of the 2 chambers, the 2 caucuses, their leaders can agree to extend that out. That has not happened for this bill yet, so it hasn't been addressed yet. I imagine it will be one way or the other, but currently that's effective until April 24th. I guess we can probably yield questions or talk about that one for a minute before I move on. I know that one's gotten a lot of attention, Dr. Scott. Is there any questions, or Samir, do you have any further comments on that?
Hey, Stafford, quick question. Did it end up having any narrow network language included, or was that omitted?
No, there were. I know there were discussions about narrow networks, and I know Dr. Scott has brought that up, and you as well, Denny. But there was that wasn't changed. I know Senator Becker, who, this was one of her babies in her bills, and she was concerned about it passing. And this was a bill that a lot of the members and legislators were on board with, and so she wanted to make sure it was passed, and that was her priority.
Thanks.
Yeah, hopefully it won't be necessary, Denny. But I think it caught a lot of the legislators by surprise, and they just weren't really familiar with it. So
Understood.
And Senator Becker is actually on the call, but she's having some trouble with her audio. So I'm working on getting her unmuted.
okay.
Quick comment from me about the language of payment parity in the setting of a rural health clinic. At the state level, most of the rural health clinics are not sure exactly what that means. For instance, a rural health clinic has a higher reimbursement rate for, we get a visit rate or an encounter rate that is higher than the typical rate of an encounter. And so the concern from many rural health clinics that I've heard from is that payment for telehealth will be at the lower kind of typical rate and not the higher RHC rate. Does that make sense?
It does, Jeff. And I guess my question is, are you talking about Medicare reimbursement, commercial, or Medicaid?
Medicaid. RHCs are on the Medicare level is probably a whole different discussion, but at this level, the Medicaid RHC reimbursement.
Okay. So great question, and we're fortunate to have Chris Chen from HC on the line. Chris, if you don't know, feel free to say we can look into it. But Chris, do you know anything about these FQHCs and rural health clinics, whether the reimbursement's going to be the same as an in-person or not? And Chris, let's just make sure you unmute yourself. There you go.
Sorry, I had to unmute both the computer and the phone. Yeah, thanks for having me. As a quick introduction, I'm a medical director for Medicaid here at the Healthcare Authority, and have been here for about 7 months. I'm an internist, hospitalist, and still practicing. So thank you for your question. I also have Jody Kunkel on the line, who is our telehealth nurse policy expert. I'm not sure this was widely known, but we actually offered parity across Medicaid on telemedicine with in-person visits even prior to Senate Bill 5385, I would say, for the last couple of years or so. And this was kind of stated in the language in our policy, which is that the payment amount for professional service, and I'm reading this right now, provided through telemedicine by the provider at the distance site is equal to the current fee schedule amount for the service provided. And so that should also be in place for the RHCs as well as the FQs. And I believe they're also encounterable services. Jody, correct me if I'm wrong there, but yeah, so hopefully that offers some clarification.
Hi, this is Jody. Yes, and on our FAQ, it actually does point out the added services we've also done that are encounter eligible. So telemedicine is encounter eligible, and it should be included on the in the provider billing guide that they maintain for those programs.
Jeff, did that answer your question?
That did. I think it's, again, from my perspective, it seems clear. I think a lot of our financial people at many small hospitals are concerned that they haven't seen that. And while, yes, it may say that, they're worried about actually seeing the dollars.
Yeah.
not much we can do about that right now, but I just wanted to point that out.
Okay. Thanks, Jeff. Samir, did you want to say anything more about the payment parity bill?
No, I think Stafford did a good summary. I'll just repeat what he said about, a lot of interest, and there's a lot of interest in seeing it implemented now. And I think there was a little bit of confusion because there was an emergency clause added late in session, but there was still the date of January 1st, 2021. So, but the governor's executive order did clarify that, so it is being implemented now. So that's good.
Great. And Samir, sorry, I didn't give you the opportunity to introduce yourself. Do you just want to say who you are?
Yeah, I'm Samir Janeja, and I'm staff with the Senate Democratic Caucus.
All right, great to have you. Stafford, do you want to move on to the next bill that was considered?
Yeah, I can check if Senator Becker's on the line yet. I don't want to step on her toes, but I can move on if she's not. Senator Becker, speak up if you're on. So 5386, you'll recall, passed in 2019. This is the bill that mandates training for those that offer telemedicine services. The 2019 bill didn't actually mandate it, but it did set up the training. And as this group did already have that training set up, but it used the word may. So if you provide telemedicine services, you may get this training, and it was a resource that was provided for them. This year in 2020, there was a bill 6061 that addressed and changed that 5386 bill language from may do the training to shall do the training. So kind of a straightforward bill, but the training that was set forth in 2019 is now required rather than optional for those that provide telemedicine training.
Is there any thought about who would police that?
That's a good question. I can check that really quick. Samir, do you have any initial thoughts?
Can you hear me now?
We can hear you, Senator Becker. Yeah, go ahead.
Oh, thank you. You unmuted me from your end, evidently. I'm over here panning. On the medical training bill, and Stafford did a really good job on that. But it was an interesting bill because people did not want it to be changed from may till shall until they learned what the background was and why I wanted that, and that was mainly for liability, etc. And so the only ones that were excluded from that bill were those MDs and DOs, and I still have a concern with that bill. The training, as you know, can be done via the internet through multiple sources or set up within an organization, as long as it meets the criteria that was established in the original bill. And I think I forgot whatever else you wanted me to talk about on that.
Stafford, any other detail there that we need to cover?
Yeah, so I'm just looking up the RCW and the enforcement. It falls under RCW 4370, which is the Department of Health. And so the Department of Health would have the authority of enforcement over this. And as the bill stands, when you get the training, you're supposed to retain a signature page that says that you did the training. I don't believe, I'm trying to read through here real quick, but as the bill stands, I don't believe it makes you submit that you did it or to get a certification or licensure or anything from Department of Health, but to maintain in your own personal records that you did. And so upon inspection, you would have to be able to provide that you did complete the training if Department of Health wanted to request that.
I'm just wondering if we might need to put together like an FAQ to share with health systems providers, whatever, on who and what and how.
Right, and
I agree,
thank you
Jenny.
for
I think that's a good idea.
Yeah, I think that's an excellent idea. This is Senator Becker again, and thank you for that. The one thing that we wanted to make sure when we wrote the original bill, if you recall, is that we didn't create a burden or a cost to you all as providers and to Department of Health for maintaining those records. So all we wanted to do was create an attestation statement and hold it in the file like you would other documents.
And I just want to remind folks who maybe are new to the collaborative that last year the collaborative did put together a video. I think it's about a 20-minute video that is accessible on our webpage. You have to click to the second page and it's at the bottom, but it does kind of cover the basics of how to do a telemedicine visit. So that is a resource if you're independent or you don't have a training supported through your institution. Okay.
Hey, it's Steph. I have a question on this bill. Did I understand that it excludes physicians from needing to do it, but everybody else is required to do this?
Senator Becker, did
So,
you take that question?
yes, if I can respond to that, we got a lot of feedback from Washington State Medical Association that they didn't want it to be mandatory, that the doctors were already doing this. And when I went to the, I'm on the board for the family medicine residency program, and asked if they did the residency, if they did telemedicine training in the residency program, and yes, they do. My concern still remains with those individual doctors out or doctors that are not associated with a large group, that it isn't mandatory, but it is being encouraged through WSMA.
And Stafford, was that a January effective date, or is this one moved up? I'm just thinking with the hordes of providers that were
It was
training.
approved March 25th, and I don't see any, so I assume it will be effective July 1st.
July 1st. Okay, that could be an undertaking at this point.
The effective
Right,
date is
especially with the amount of people we've brought on.
Right.
The effective date is June 11th of this year.
Okay, but you also have to remember that organizations can set up their own training within their large organization. So this won't hit just one particular area, group. Like I'll use Providence, for example, can set up their telemedicine training, and Virginia Mason can set up their telemedicine training. The thing is that it has to meet the criteria that was established in the original bill.
Senator Becker, I think just one of the challenges that we've faced is keeping up to date with all the different laws that have passed, both Medicare and Medicaid. So we revamped our training about 2 weeks ago, and it's already out of date. So just an FYI that in this very fast changing times, it's sometimes hard to keep up with the actual billing side of things.
And I would anticipate, Dr. Scott, that will be the case for a number of years to come. But I think that just maintaining that training standard is going to be harder than we anticipated. But again, the physician needs to take that, or the provider needs to take the training and show that they met the standard at the time, and not every week.
Thank you.
And if I can jump in, Sean Graham did just clarify. Thank you, Sean. The bill is effective June 11th of 2020, but the provision requiring the training in the text of the bill does say January 1, 2021 is when those training provisions will be effective.
I see. So we do have about 9 months of grace period. So thank you.
Well, thank you, Sean, for pointing that out. And just to further clarify, the text of the bill does exempt physicians licensed under Chapter 18 and also osteopathic physicians. The last bill that I assume that we want to talk about and that was relevant from this session was 5389, the telemedicine in schools bill that did not pass. And I'll defer to Senator Becker if she wants to talk about that one, or I certainly can as well, Senator. Senator Becker, are you still there?
Randy, you might need to unmute Senator Becker if you can help us with that.
I don't see her connected. Let me try here.
I think she may have dropped off.
Oh, I'll go ahead and talk about this one. I feel like if she comes on, she can take over. This bill has been discussed quite extensively in this group. It's the bill that would provide telemedicine services to students in schools. This bill is going to expand the current pilot program of 2 school districts to 4 school districts. And then there were other changes, but the intent of the bill was to provide telemedicine services for mental health students or those who are a danger at risk to harming others in schools. This bill made it further along this year, though it did not ultimately pass. It passed out of the Senate, unanimously, made it over to the House, made it out of the Education Committee, but did not pass out of appropriations. So the telemedicine in schools bill did not pass. I know that was one of Senator Becker's priorities, and I don't know what form or shape it will take moving forward. I would defer to Senator Becker on that, but that was just an update on that bill because I know that we've discussed it here.
Okay.
Can you hear me?
Yes,
Can you hear me?
Go ahead.
Oh, okay. Well, I think Stafford did an excellent job. I was totally disappointed that that bill did not pass. I know that Dr. Hiltz and I worked extensively towards the end there to make sure that we had a fiscal note that was within reason. I am not sure why approach did not move forward, because it actually was a very reasonable amount of money. And what the bill would have done is increase the number of school districts to 4 in a pilot project over the next 3 years, with a reporting requirement back. As it stands right now, the bill is actually still alive in the form of a pilot program that, as you know, we put it forward last year, where the education or the training portion of it was being developed. And now this next year, the actual working of the bill, meaning reaching into those 2 school districts. One is Sumner on the west side, and the other is Medical Lake on the east side. And they will be able to work on that pilot project and report back. And hopefully we'll be able to move that bill forward in a different way next year, and hopefully have approach really paying attention to it for the financial part of it. When Ian Goodhue and I were looking at what it would cost to bring every bit of the state live with this, it was in the range of $70 million. But $70 million is cheap in comparison to the rest of the treatment options that would be available to students and the long-term effects. So this bill is actually still alive in the pilot program, but that means that it's only good for 2 years. So next year there will need to be a bill that moves it forward. Fortunately, Christine Rolfus, who's chair of Ways and Means, is really involved in this as well, and hopefully we'll be able to get it moved forward next year. Someone else is going to have to be bringing that bill forward. As you know, I announced my retirement, but that does not mean that I'm going to quit working on getting mental health into schools.
Thank you, Senator Becker, and it's a great loss to not have you in the Senate. Thank you for your service.
Thank you. It's been my pleasure, but I still have until January.
I wanted to just let folks aware of a chat from Tiffany Chaum, who raised this issue that there's some people holding themselves out as telehealth trainers, and that they're not necessarily giving accurate information. So I think the bill is pretty descriptive of what needs to be in the training. Tiffany, maybe we can follow up offline and how we can get that information to the social workers and the groups that you work with to make sure that they're getting approved training and good training. But thanks for raising that. So I think in the interest of time, I would like to move us along to our next agenda item, and that's to hear from Dr. Chen and the Healthcare Authority on some really exciting programs that he's been rolling out. And so I'm going to turn it over to you, Dr. Chen.
Great. Thanks again for having me. Chris Chen from the Healthcare Authority. So I just wanted to share with you guys, we have been very active over the last few weeks. I think that might be an understatement, just kind of recognizing that our delivery system is undergoing a massive change as a result of the social distancing requirements, the strains on the healthcare system and PPE, et cetera. And so from a policy and programmatic perspective, we've been very much staying tuned. We're trying to stay tuned to the needs of the community. And just as a high level overview of things that we've done over the last few weeks. So I touched a little bit on parity before, that we had parity across Medicaid, fee-for-service, and MCOs for in-person versus telemedicine visits. And when I talked to my Medicaid medical director colleagues across the country in a couple different forums, I think that fortunately we have a little bit more progressive of a telehealth environment here compared to other states, including allowing for home-based services and also allowing for different types of service. We've had some requests, for example, from hospitals where PPE shortages necessitate video visits into the room from the nursing station, and that's something that we allow, and other kind of situations and types of service. And so trying to be supportive of those, and also had our store and forward program that there's some coding changes that recently came about for e-consults, and so that we've turned on as well. Other kind of changes that we've made for the pandemic, recognizing that a number of our low income and vulnerable populations may not have access to telemedicine technology, specifically audio video. We've opened up phone codes as well and have those mapped to in-person visit rates for the duration of the pandemic. Also opening up other codes like virtual check-ins. G2012 is one that you guys might be familiar with, and as well as digital online services. We've tried to issue some clarifications on policies for other services like physical therapy, occupational therapy, and speech. And Nicole shared some of those FAQs that we've put out on our website that relate to all of these policy changes, as well as specifics on behavioral health as well. Some of the other ways that we've been trying to be a little bit more creative in supporting our safety net providers. You may have heard about the Zoom license program. And so recognizing that there was a need for telemedicine audio video technology, we directly procured licenses from Zoom. These are HIPAA compliant, 42 CFR Part 2 compliant licenses that we've been issuing to providers serving Medicaid members, and our distribution policy really tries to support those smaller providers who do not have as much infrastructure and may serve children, adolescents, pregnant women, tribal members, those with serious mental illness, community mental health centers, etc. And we've had a lot of interest in this program and have been actually actively issuing licenses as well. And then also, yeah, I've been in communication with Dr. Scott and trying to understand some ways that we can provide support to the provider community, especially for our behavioral health providers, working with the UW for potentially with UW for technical assistance, or trying to understand other ways that we can provide technical assistance if there are other avenues, channels of information that we can support as well. We've asked all of our plans to be transparent and make their telehealth programs visible. Generally, they follow our policies and our billing guides, and the guidance that we offer through fee-for-service. And so, yeah, it's kind of a high-level overview of things that we've been working on here at the Healthcare Authority.
Great, thanks, Chris. I know you've been super busy. Maybe I could just follow up on the Zoom licenses. Let's say I'm a solo provider in Moses Lake. How would I go about getting that license? And can I use it for non-Medicaid patients, say like Medicare, things like that?
Yes, we do ask that providers not use the licenses for personal purposes, but these are meant to support communities, and we are payer agnostic for the visits that these are conducted for. And there's a link on the HCA website that I'll post in the chat box and also send to Nicole for how to request a license.
Great, thanks, Chris. Marissa Engel also said that there's a lot of interest from the ACHs in providing their provider partners with this telehealth implementation, including some basic IT support. So just know that there's resources available beyond the ACA.
Great, thanks so much. Yeah, we've been keeping in touch with the ACHs as well, and I think I'll be on a call with them on Monday to see how we can work together. So thank you for bringing that up.
Any questions for Dr. Chen? Okay, well, thanks again, Chris, for coming today, and look forward to hearing updates. So I think we next wanted to talk to Dr. Brian Marcus at Seattle Children's, and Dr. Mary King, who splits time between here at Harborview and Seattle Children's. So I'm going to pull up your slides, Brian and Mary, and just tell me when to advance them, okay?
Fantastic. Thank you, John. Just real quickly, just because y'all don't know us, I'm Dr. Mary King. I am a pediatric ICU doc working here at Children's in Harborview. I'm the director of the trauma ICU, the pediatric trauma ICU at Harborview. But I also have served since 2012 on our regional coalition disaster clinical advisory committee, as well as the state one over the past 4 or 5 years. So, and I'm actively involved in disaster preparedness here in Washington State. This past year, I also became the Washington lead for a West Coast ASPR Pediatric Disaster Preparedness Grant, creating a Pediatric Disaster Center of Excellence on the West Coast. And so wearing these kind of medical director hats at Harborview, as well as the Pediatric Disaster Preparedness hats, I became involved when my residents started coming to me telling me that they weren't able to see patients in their outreach clinics. And then we approached some of our, one of our pediatricians, our community pediatricians on our DCAC, who said similarly, they didn't have access to see their sick patients. So that's how this project started. I'm going to introduce, this is my senior resident, Dr. Brian Marcus, who has worked like a dog on this project and has done amazing work. I'm going to let him present kind of our small public health project that turned into some pretty exciting work.
Hey guys, so as Mary said, I'm Brian Marcus. I'm a senior resident here at Seattle Children's. And you can click this slide over because it's got a lot of info on it. And so this is sort of a visual abstract of the paper that Mary and I have written. But essentially, as Mary said, it became clear to us early on that because of some public health messaging to stay at home, that primary care was sort of being routed around. In my own clinic, I was going there and having the whole day of empty slots or just a couple well child checks because I didn't have means to do telehealth. And so I work, with Seattle Children's, I work with UW. And so first, we looked internally and it became clear that these large networked organizations had access to telehealth services. And, John Scott rolled out Zoom at UW in rapid fashion. And I think this was happening at similar large networks around the state and around the country. And sort of what we realized is that the non-networked and or poorly resourced individual clinics may not have this sort of support. And so on March 6th, we had this phone call with, some of the community pediatrician leaders of the region. And it became clear that our concerns were real and that while the big networks had access, little clinics didn't. And so on March 7th, we sent out a survey to 15 clinics, mostly in King County, a little bit outside it as well, and you'll see that on the next slide. And just asking them a few simple questions. And I think the biggest thing to present is that not a single one of these clinics had any telehealth capabilities. And what we realized over the next week is that it wasn't that they couldn't do telehealth, it was that they just weren't there yet. They needed encouragement, they needed support, they needed education. And so when we realized this, we started recognizing that we needed to ally with our medical societies, because what we really needed to do, as much as we needed to support individual clinics, we needed to get out mass information about, like, hey guys, it's available, it's out there, there are all these vendors. And then it became clear that the vendors were getting swamped, the free options were going down, VC and Doxy pulled their free options, and that's sort of like when we met Chris. Chris at the HCA was already rolling out telehealth capabilities for behavioral health providers. And we sort of asked Chris, like, have you considered that there's this need on the medicine side as well? And within a few days, the HCA totally changed the model and allowed the Zoom licenses to not just behavioral health, but medical providers as well. You know, at this point, we felt that access was significantly improved, and we sort of turned our mode a little bit to advocacy, because we were getting feedback from all of these clinics that, while yes, that now they were educated, they had support, they needed parity billing. You know, my hospital can send out emails saying, don't worry about billing, we have professional coders, if we don't get paid, it's no big deal. But this was not an option for the individual clinics, certainly for the solo practitioners. And so we allied with King County Medical Society, the Washington chapter of the AAP, and the Washington State Medical Association, and just started to do everything we could to get parity billing passed. And I think the fact that the Senate Bill 5385 was already passed, and the only barrier was removing the January 2021 date, was so critical, because people could see the vision that it was right there. And so we reached out to the private sector, we reached out to the government sector. Regents announced on May 19th, and then a week later, the governor announced. And the WMCA and the Washington chapter AAP really did an excellent job reaching out, actually all the way up to our congressional leaders to coordinate talking with the governor, because after the California emergency action, it became clear that rapid emergency action was going to be required to come through the governor. And we have been in touch with 45 clinics, and we'll probably follow up in about 1 to 2 weeks directly and across the whole state to see how telehealth is going, what the major obstacles are, and how the state can be helpful further. And I will stop there.
Can I show them the clinics?
Oh, yes, and can you flip to the next slide, please? So this is a regional graph of the first 15 clinics where we did the needs assessment and really started our program. And if you click one more, you will see that this is the regional spread of all the clinics that, like, I personally, Mary and I personally, were in direct communication with. And most of them are small, but I know, like, the dot at Newport was actually the medical director over there that John Scott put me in touch with. And so I think some of those dots actually have significant spread within their region. And I think, to me, it's super impressive that we really did achieve at least some state coverage in just a few weeks.
Great, thanks, Dr. Marcus. Dr. King, is this only for pediatric clinics, or is it family medicine?
So, yeah, we started out just looking at pediatrics because obviously that's our area of interest and expertise. It's where we had contacts. But there's no difference between pediatrics and family medicine and all the other different types of medicines that are out there in the community. And so when we spoke with Chris initially, we made that very clear that this is not just for pediatrics, because we were already getting questions when we were talking to these clinics. Well, what about my colleagues here? Or what about my family medicine clinic here? So it's definitely not unique to peds. It's just where we had a voice. It's also where we had connections for advocacy as well through the AAP.
Great. There's some chat questions about the security with Zoom. because I think there's been some things in the lay press about what Zoom records and things like that. So I know at UW we had our IT security folks take a look at this. And we have a BAA, or a Business Associates agreement with Zoom that says they need to abide by the principles of HIPAA. And I think it's going to be probably more. They're making a mountain out of a molehill. What they record are just you know, any kind of quality issues, like the packets of audio getting interrupted, and so that's really what they're tracking. But there was a chat that Zoom has been named in a lawsuit in California. So I don't know if other people have more information about the IT security of Zoom.
Yeah, so I think Tiffany actually sent out an email about this on one of her listservs. And this was from Zoom itself. It's the concern in lawsuit is only for non-healthcare Zoom. And Chris can correct me if I'm wrong, but it's my understanding that the Zoom licenses that the WAHCA is offering are the healthcare. They're a cut down sort of slim version, but they're the Zoom healthcare side. And so they'll be covered under the BAA and not a part of the class action lawsuit. I'm not 100% sure, but probably like 95%.
Hey, this is Chris. And yes, our licenses were procured under the Zoom for Healthcare HIPAA compliant program and are covered under a BAA. Additionally, we have configured a number of options that reduce the likelihood of video conference hijacking, such as requiring that all providers have all the guests that are introduced into a virtual meeting room placed in the waiting room. And that option is locked down and configured, only allowing the host to screen share and not others to screen share, and that is also locked down. We've advised members in a webinar for enrolling in the Zoom program to only distribute the link to patients. And so that is also another safety measure there.
Yeah, and Chris, just one other thing that we, in our HIPAA compliant version of Zoom, is you have to disable the record function. So if you look at this is actually being recorded here, but you would never want to do that in a patient interaction. So,
right.
Yeah.
So yeah, that's Chris. Yeah. One question. So one question I had for the group was just, and Chris, maybe you can answer this, in terms of from here on out and messaging to unconnected community providers, be they behavioral health or medical, how do you need support in that messaging, or what is the plan from here on out to try and reach them?
And I will just add real quick. So we got it sent out through the WMSA, the WCAAP, and the King County Medical Society, because Chris sent it out to all stakeholders in healthcare. That was the email sent to.
I just don't know how much the lay provider who's busy in a clinic has access to some of that information. So just as a provider kind of in the hospitals or in the clinics, how are we going to make sure we're reaching them?
Yeah, we have sent our announcement about the Zoom license program through a number of communication channels, including the ones that you guys suggested, as well as some of our, we have this platform called Gov Delivery that is basically a big listserv that with specific populations outlined, and we sent it out through that too. This is available on our website, and we're happy to share this link to anyone that's interested. Yeah, I think there's stuff around Zoom itself. We are asking, because our IT, for example, doesn't have the capacity to support all the technical support issues, and that's kind of what Zoom is there for. And so if there are, issues with logins or passwords, et cetera, that people go directly to Zoom. And I think we're also trying to figure out the kind of support around telehealth in general. A lot of providers might be practicing telehealth for the first time with some of these licenses, and just trying to point people in the direction of the best resources You know, I'm personally not a telehealth expert, but I know there are a lot of really fantastic resources, NRTRC, the Telehealth Collaborative, that can kind of talk about things like best practices. And so I think trying to figure out what the right resources are.
Okay, and then last question for the group potentially is, you know, I know there's a lot of public health messaging out there to stay home, stay safe, but especially in a family situation, if a patient gets sick, especially a child, but I'm sure older parents too, I feel like sometimes there's a disconnect and people really feel like they need to go see a doctor. Yeah, despite the kind of layperson messaging that's out there. And so they think it's an emergency. They think they have to get tested right away and they have to be seen because that's going to fix it. And I'm just wondering if there's any platform to leverage. To feel like, to get the message out that it's not just stay home, stay safe. It's especially when you're sick. We have this opportunity to get you information, get you care, but please stay out of the offices if you can. And I just don't know how we get that messaging so that it's heard by the people we need to hear it.
You know, Mary, I think you bring up a really good point, and sometimes that just needs to be a one-on-one discussion, either through the phone or video, and sometimes they're just reassured that you've laid eyes on them.
Right, totally.
Yeah, you know, and I know that just the volume of calls has really overwhelmed people. So when we get to sharing about ways that we're trying to scale up, I think that our colleagues at Providence and also UW, we can talk about how we're using chatbots to kind of push out some of that messaging.
There should probably be some messaging around the importance of that, having that flexibility to message your patients directly, because I think you get something from up on high from a public health officer, it's one thing, but you hear something from your doctor, even in a chat box, something like that, it's super powerful. So to leverage that one-on-one communication in some way, I think would be really great.
Yeah, okay. Well, great. Just a note, Chris, that I think there's a lot of questions from folks about the IT security around Zoom, and for all of us who are using any platform, not just Zoom, but people are justifiably concerned about security here. So thank you, Mary and Dr. Marcus. We're going to move on to the next agenda item, and I think that's Jim Goldroff. And let me just take down my slides, and I'll turn over to Jim.
Hey, good morning, and thank you for allowing me to join your meeting today. So just by way of introduction, my name is Jim Vollendroff, and I'm the current Behavioral Health Service Line Administrator for UW Medicine. And before joining UW Medicine, I was the director for the King County Behavioral Health and Recovery Division for 16 years. And so I'm here today for a couple of agendas. One is to bring you up to speed on a proposal that we submitted to the State Healthcare Authority and the Division of Behavioral Health and Recovery related to a rapid telehealth response to behavioral health providers, particularly those behavioral health providers that serve the Medicaid population. And two, to see if I could add your organization or your group to a growing list of organizations that have agreed to sign on to our idea and to act in a capacity of consultation if we need a consultation as we go along. So I'll start by just going over the short summary. It's on the agenda, but I just quickly will go over the first part to make sure everybody's clear about what we're trying to accomplish. Some of it's been discussed already, but I will say I've been steeped in the behavioral health community for 30 years here in this state, and so I know it well. And although advances have been made in telehealth in many arenas, it's less so true in the behavioral health Medicaid provider community in particular, particular organizations that don't have the infrastructure that larger organizations have. So we rapidly pulled together a group of people that will be centered out of the Behavioral Health Institute at the University of Washington Harborview Medical Center. I was the founding director of the Behavioral Health Institute. And the first thing we set up was a center for workforce training and policy related to behavioral health as a component of the Behavioral Health Institute. And so this project will be led by Melody McKee, who is the program director for the Workforce Training and Policy Center of the Behavioral Health Institute. So our goal is to have our project is called the Behavioral Health Telehealth Rapid Response Team, and we will provide statewide coordination and mobilization in partnership with providers, including the Healthcare Authority, DBHR, MCOs, ACHs, and University of Washington and others to respond to behavioral health telehealth deployment, training, and technical assistance. We also have a longer, broader proposal related to digital health more broadly in the Medicaid behavioral health world, but our immediate attention is the continuity of operations of providers that serve Medicaid populations to ensure access to care, equipment, technical assistance, billing, staff training, etc. So that's in a nutshell what we're trying to achieve through this proposal. And again, I'm hoping that we can get your endorsement, if you will, on this, and some opportunities for helping us as we organize this initiative moving forward. So I'll stop there. I will say that I heard a mention of meeting Dr. Chen with the ACHs. I just got off the phone with the ACH executive directors this morning. And I have also talked to all 5 of the managed care organizations. And collectively, the 3 of us, in addition to other partners, have all agreed to collaboratively work towards a single portal for the deployment of telehealth behavioral health, again, particularly for the Medicaid population, and centered around the Zoom licensing that the Healthcare Authority is purchasing. Providers can choose any platform that they wish, but if they want to get support, they want to get good information and accurate information, everything from the equipment to access to billing, etc., we're going to be focusing on the Zoom platform initially. So I'll stop there and let folks ask any questions. And again, I appreciate the opportunity to make sure that this group is aware of this body of work.
So Jim, great, thanks for that summary. I guess, can you just focus on what is the ask for this group? How would we be supporting your efforts?
I think that, again, what I would ask is that this group sign on. I can actually, I think, let me pull it up here. I've got. I have a written proposal that we submitted to the Division of Behavioral Health and Recovery that they accepted on Monday. And in there, we start with proposal partners. And the partners identified have approved our proposal, they've reviewed our proposal, and they've agreed to coordinate. So by signing on, they're indicating enthusiastic support for this proposal and the structure of a statewide approach for the delivery of behavioral health rollout for the Medicaid population. The list of partners will also agree to be part of a task force, if you will, or a group that gets together on a regular basis to figure out how do we coordinate this in a way in which it's helpful to the provider network that are serving the population. And so far, the partners that have signed on are Harborview Medical Center, the King County Behavioral Health and Recovery Division, the ACHs, the Washington State Managed Care, the MCOs, University of Washington Digital Health, the Washington Council for Behavioral Health, the Washington Recovery Alliance, the Washington State Hospital Association, SEIU, and the Association of Alcoholism and Addiction Programs. And what I'm hoping is that I can also list the Washington State Telehealth Collaborative.
Well, this seems like a really worthwhile effort to improve access to mental health care around the state. I mean, and telehealth is really going to be the way to do it. So I'm just going to see if there's members of the collaborative that have concerns or questions for Jim. But
this is Cheryl from Primera. So I don't think I have a concern. I do have a question. Is this specific for Medicaid, or would this also apply for commercial providers looking for how to provide telehealth services?
It is, I think that the Healthcare Authority has indicated that the use of this platform is payer blind. And so I think that it can be used for any population. The training and the population that we're focusing in is the public behavioral health provider network. And many of them have a diverse payer mix. And so if they are seeing a diverse population of clients with different pay sources, they can use it with that population as well.
Okay. And is there a website we would direct providers to if they're interested, or how would that work?
There will be. We just were awarded the contract, or the proposal was accepted on Monday, and so we are currently working on all of those things now. We have a rapid response team that is meeting on a daily basis, and the development of a single portal for that kind of information is high on the list. One of the things that we're trying to accommodate is the fact that the Healthcare Authority has been very responsive and trying to get information out quickly, and so have the ACHs and a lot of the national organizations. So there's a lot of information coming out to providers, and so we didn't want to put the brakes on anything that's in process now, but trying to figure out how do we seamlessly incorporate all of the current initiatives that are happening into one place, and that's what we're working on now.
Jim, it sounds like
sounds good to me.
Yeah, I mean, Jim, it sounds like it's very symbiotic with what Chris Chen is trying to do. And I just want to make sure you guys talked. Chris.
We will. Chris, I'll give you a call. I'll connect with you. I'd love to talk to you before you talk with the ACHs, just to fill you in on my conversation. So I had a very similar conversation with them this morning that I'm having with you, and I left them with their task to come back to me with whether they were supportive. They've generally given their support. They wanted to have a conversation, and Susan McLaughlin just texted me and said, hey, let's talk. It looks good. So I'm assuming the ACHs are all, they've pretty much given indications, but I wanted to be able to have this kind of conversation with them.
Great. Yeah, sure thing, Jim. Sorry I missed that meeting on Monday. I've been connecting with Carrie and Michael Langer, but yeah, it would be great to chat.
Oh, good. Great.
And Jim, one other person who's on the call who I think it might be great to loop in would be Sean Graham from the Washington State Medical Association. And I'm just wondering, Ray, Hanley, and LNI, does this touch you at all? Is this something you'd be supportive of? You can either give me the thumbs up or thumbs down, Ray. Okay, thumbs up. Okay, great.
Thanks, Ray.
Great, and Jim, if you don't know, Sean Graham will want to connect you offline. But if it's okay with everyone, I think this is a very worthwhile effort. And as a chair of the collaborative, I'd like to endorse Jim's efforts in this area. Okay, seeing lots of head nodding. Feel free to shoot me down now. Okay, great. Thanks, Jeff.
Okay, great. Thank you very much. And I will figure out a way to keep you guys informed of our work going forward, and how to loop in when we need technical assistance or support moving forward.
Sounds good, Jim. And
thank you.
Look forward to getting an update from you on that.
Great, thanks.
Okay, so what I want to do next is move to the last hour of our meeting, and this is where we want to open it up to members of the collaborative and just share a slide on what they've done and some of the challenges. So I'm going to kick it off and share my screen here. So do that. Right. And thank you for those of you who sent your slides ahead of time. So first of all, I want to start off with a slide from Mr. Rogers, who said, when I was a boy, I would see scary things in the news. My mother would say to me, look for the helpers. You always find people who are helping. So, you know, this is a time where we need everyone to help out, and those can be in very small ways, and they can be in big ways. So I just wanted to share some of the things that the University of Washington has been doing in the last month. And just to start off with a strategy, the first and most important strategy has been to leverage our pre-existing training our pre-existing technology and our pre-existing relationships with vendors. We did not want to try to make a whole lot of change because this is going to be a massive amount of change, and we didn't want to introduce a whole lot of new technologies and processes. So the first thing that we moved very quickly on was scaling up all of our teleprimary care. We had about a third of our providers already trained in doing telemedicine, and a lot of that was a result of the snow event of February 2019. So we had a lot of those people ready to go, and pretty much scaled everyone up and have a ton of providers who have been credentialed, almost 2,000 now. And so those folks are out there and seeing patients. I think the latest count was 7,500 visits in the last 2 weeks just in our neighborhood clinics through telemedicine. The second thing we did was to optimize our virtual clinic. So this is something we provide through a vendor, an outside vendor. And we made the decision to make that free as of March 4th. And our visits went from about 10 a day to well over 100. And initially we could kind of handle that volume because Seattle and Washington State was at the vanguard of the outbreak, but then as other parts of the country got affected, we really saw the wait times going up. And so what we've done is, starting today, we're breaking it out to have a COVID-19 only response. And we're bringing on some of our furloughed providers, particularly in emergency medicine, to help handle some of those calls. We're still going to make the COVID-19 virtual clinic free, but we are reinstituting that for non-COVID-19. There is a small fee for that use of that clinic. And the nice thing about having the COVID-19 is then they can refer them for testing and put in orders and things like that. The other thing we're working on is scaling up telemedicine for vulnerable populations. So those are our oncology patients, transplant patients, HIV patients, patients with end organ disease. And many of those clinics are going live either this week or some went live last week. We've gone live with a chatbot with AWS and Amazon, and that has been rapidly scaling up, helping out. We're looking into remote patient monitoring. So for these are patients who may have COVID-19 and they don't meet criteria for admission to the hospital, but we do want to keep an eye on them. And also on the flip side, patients who are being discharged, we want to make sure that they're doing okay. And we are expanding e-consults both internally and externally. The other thing we're doing is a tele-ICU. We did not have a tele-ICU when this all started, but many of you know how important it is to minimize your burn rate of personal protective equipment. And by having the ability to talk to the patient, see the patient remotely, that's going to help with our burn rate. But also is allowing us for load shifting. So one of our hospitals has been disproportionately affected, and they didn't have 24/7 intensivists when this all started. So this has allowed us to get those people involved. And you know, our workforce is really our most precious resource, so we want to protect them. So some of the challenges we face is just the incredible amount of people who needed to go through the system. So scale was such a huge challenge. So getting people trained and getting the equipment. We released some of the controls we had on that whole approval process. We've made training available to all of our providers now. It's an online training. And then, not surprisingly, we had some shortages on webcams that we encountered. And we were able to leverage some relationships with some of the large tech companies to meet that demand. And then I think the last issue is just how quickly things are changing. It seems like every day there's something new from Washington, D.C. And I think the general direction is that a lot of those barriers on reimbursement have pretty much gone away. So that's all good, but it's hard to keep up with all those changes and to message that out to my colleagues. So that's all I had. Are there any questions? Okay. Well, if not, I'm going to turn over to Dr. Frank, who is an emergency medicine doctor at Confluence. Josh, do you want to tell us what you guys are doing in Wenatchee? And I know Josh is having a little bit of audio issues. Josh, do we have you? Okay, maybe we'll come back to Josh.
Josh, if you're on your phone for audio, you can press *6 and that'll unmute it.
Randy?
I'm here. Can you hear me now?
Yeah, there you go. Go ahead.
Very good. Thanks. Sorry, I got no video, but it looks like I got sound. Great. I'll tell you that this has really helped our local telemedicine effort. And it's been nice to see everybody work together. I'll tell you, things move quickly. March 2nd was when we had our HICS team convened, and that next week, of course, the phone calls started. And pretty quickly, the Department of Public Health was overloaded. And so our own hotline had to be developed. And so we just handled all the calls. That moved into kind of a nurse scripted way of handling them. And it became clear that everybody was going to want to use telemedicine as much as they could, and that it was a way to route people through the hotline to the right people to use telemedicine means rather than live visits. And I think everybody started thinking about scaling up the very minimal telemedicine programs we had already very quickly. And much of the medical staff started getting educated very quickly. Information was pushed out to them. And then people just started using what they had. If you recall, the regulations became relaxed, and people are able to use the phone and actually get reimbursed for phone visits right now. They use FaceTime, they use Zoom, and they were using Doxy.me as well. They were just really using everything that they had available and then documenting in the chart appropriately. At the same time, I also noticed that the telemedicine companies that are national, like that I work with, all of a sudden New York, Florida, Nebraska, Mississippi, North Carolina, I mean, loads of states, all of a sudden those came to my inboxes, and because the credentialing requirements were relaxed in all those states, they were opened up too. It all happened at the same time. And then, so a more organized approach has been developed now. And as of March 17th, we established a virtual visit kind of workflow, which incorporated all the different media possibilities, but we're moving towards an organized portal that hopefully everybody will use, and that'll be standardized. And as of March 23rd, we had a solution through our Epic system that partnered with a company called Caregility. And so now there's a organized platform everybody can use through the Epic system, and patients receive a message through their MyChart. It brings them into the visit. The offices can schedule these visits with providers, and then the providers can easily go in and notify the patients they're ready. It's a pretty smooth system. It's very user-friendly for the patients because they don't have to download any applications on their end. It just works automatically with their device. It's not recorded, but of course they do normal documentation. Education is getting very good to the providers at this point in time. And initially, it was just minor complaints that were recommended, the kind of things you see in urgent care settings, and then also people who were concerned that they had COVID. However, it's being expanded now because, of course, like a lot of places, a lot of the outpatient clinics are decreasing their traffic. So general surgery, orthopedics, cardiology, these kinds of clinics that normally would have a lot of live visits are just switching over to telemedicine visits, and it's happening. So it's very nice to see people responding quickly. They're working together. We had a little bit of a infrastructure, very minimal initially, and that's been scaled up and it's getting organized, and it's really showing results.
Great. Thanks, Josh. And I just wanted to highlight the importance of standardization that Josh mentioned. And at some point, I'd like to come back to this, but my billers have said that there's a lot of different policy out there, particularly around a POS or the place of service code. Should they use a 2? Should they use a 12? So I just want to flag that particularly for folks at Regents and Primera and Molina Kaiser. To the extent that we can agree on how to code this and bill it, that would really make things a little bit easier. So great. So thanks, Josh. I think what we'll do is go to the next presentation, and that's from Chad Gamelin at Virginia Mason. Chad, do you want to tell us what you guys are doing at VM?
Yeah, I guess I must not have gotten my slides in on time. I apologize. We've actually been really busy, as I'm sure everybody else has. We've endeavored to virtualize our entire primary care teams as well, all of our subspecialty ambulatory services. And so our primary care teams are live. I think we're up to about somewhere just shy of 700 visits a day at this point now that are being done virtually for primary care. Our Department of Medicine and subspecialty teams are in various processes of go live. And so like what you mentioned, John, obviously we've had to train up several super users, if you will, train the trainer models, and then scale out the building and development of hundreds of different virtual waiting rooms for each one of the providers. And so everything from schedulers to frontline teams are busy getting trained as we speak. And then, some of the highlights on the inpatient side, we are using our telehealth carts in various parts throughout the hospital, including the emergency room, as well as our critical care units, so that patients that are requiring kind of frequent high touch, when we can, we're using either nurse facilitated exam models or just kind of what we're calling check-ins virtually, where docs are beaming in to see those patients. And so our first phase in that realm was literally bringing up all of our intensivists, our infectious disease docs, and then all of our ED physicians. And right now we're in various stages of implementation with our hospitalist teams, our therapies, and our social work group. And they're going through training as we speak. So some of the things that, I just really want to call out, John, you highlighted a couple of things, and that is that there is definitely a shortage of webcams, and we certainly are grateful to our community partners who have been donating that equipment, but it's pretty hard to get your hands on 1,000+ webcams at this time. So, for other folks out there, I would certainly, that are trying to tackle this, I'd certainly welcome a conversation if you have any insights. The other thing we found out is that we have 3 different telehealth vendors in our ecosystem. And one of our primary vendors has been having a difficult time keeping up with the load. And so on our ambulatory side, we've noticed some of the patient experiences haven't been as optimal as we'd hoped for. And we've had to increase bandwidth throughout our house, in addition to them bringing up servers, I think, nationally. So those are kind of some of the things we've contended with. We do have a COVID hotline as well. We certainly have mobilized an entire team of folks that are now doing virtual care. Any questions?
Thanks, Chad. That's quite a bit, 700 a day.
Yeah.
So question for you, Chad, and this is a question I get from a lot of my providers is, there's some reluctance in even advertising this to patients because they don't think that they're going to be able to handle some of the technology and things like that. Have you encountered that, or for the most part, patients able to figure it out?
So I just anecdotally, and I don't have hard data on this, so you guys try not to, I will say that 90% of the time, if there is a less than superior patient experience with a video visit, it typically is their bandwidth. And the way that we've addressed this is we've built out all of our virtual waiting rooms to send out advance notification just prior to their visit. And we're instructing patients that they really have to check their bandwidth before they do the visit. And so we've been trying to key in on that educational piece. And so like our frontline call center, all of our front desk staff, they message that to patients over and over again so that there's multiple areas of touch. We're also trying to discourage people from doing this in public areas. We're still getting kind of interesting different scenarios where people are using their phones out in public and stuff like that. And so we've kind of had to do a lot of patient education in that realm as well.
Yeah, that's a great point. And I know what we tell patients is please get on Wi-Fi if you can, rather than over cellular.
Absolutely.
And for folks who may not know, a lot of the internet providers have offered free or really reduced broadband during the time of COVID-19. So you may have low-income patients who don't know about that. It's a great resource to look into. Great. Well, thanks, Chad. I think we'll go to the next presentation. And that's Ray Hanley at Labor and Industries. Ray, do you want to tell us what's going on there?
Can you hear me okay?
Yeah, we can hear you. Go ahead.
Okay, great. I made this into kind of three things. The first part really, of course, with all the workplace involvement, we've got, I just wanted to talk about the quarantine first responders and healthcare workers are covered. So a little bit about our policy. By workers' comp, even if COVID-19 is not contracted. And other workers, it's on a case-by-case basis. So just a general policy statement. And then we started getting a lot of questions about testing and testing pricing. Those questions have fallen by the wayside recently, but testing is paid for if work-related exposure is documented, even if someone doesn't fall ill. So those are just sort of the general workplace policy statements that we've got. In terms of telemedicine and telehealth, this has really been a rapidly evolving couple weeks for us. We have put in place some temporary policies, and it seems like from one week to the next, we may have to change those policies. But I mentioned a couple here that we're working on right now. Telehealth allows a group as the originating site with group psychotherapy. We do have payment parity. Telerehab, which is something that we've been looking into, as you can imagine, for injured workers. So we've moved that into physical and occupational health. And again, these are temporary policies that we're working on right now. And as a State Department, of course, we have to use different ways to get the message out to providers. They have to go through communications clearing, et cetera. So these policies are online or coming out this week. Then we have something called SIMP, which is defined at the bottom with the asterisk, but it's an intensive medicine. It's about 4 or 5 hours of intensive different providers, occupational therapists, physical therapists, working with a patient up to about 20 hours a week in the clinic. And we've had to take, for continuity of care and to try to adapt to this changing environment, we've had to take a look at the way that SIMP is being currently delivered and look at some new ways to do it. We've been out talking to providers that provide these types of services and getting input from them about what's possible. A lot of this is really, really new for injured workers. We've got some other telehealth policies that are under review. An interesting one is when you need an interpreter for an injured worker. Roughly 1 in 10 of our injured workers need an interpreter and use an interpreter. We provide on average about 700 visits a day that use interpreters. Those interpreters, of course, have a new role now in this new world order. Moreover, we have contracts for telephone interpreting, which does not include visual, as opposed to telemedicine interpreting. So we have 2 different contracts. And so right now we're working through ways to try to accommodate both the master contract that the Department of Enterprise Services provides to agencies to use for telephone interpreting, as well as trying to keep our face-to-face interpreters and the continuity of care for our injured workers going. So it's really been building the plane like everybody else while we're flying it, but we're staying ahead. Telehealth is something that maybe it's just me because I'm old, but telehealth still means real-time audio-visual connection. But at least for some people, certainly smartphones have blurred the difference between telephone. And I heard the gentleman from Virginia Mason, as well as you, John, talk about how people are taking calls in all sorts of different places. And when you have an injured worker, you have liability and lots of legal restraints. This is a very important time for us to make sure that we have good connections and that we're making good decisions, that we can stand behind it, don't put either patients, providers, or the state at risk. I might also add that another thing here, and this is just my opining a bit, but the financing for labor and industries is dependent on employers and employees. It's not state general fund. And so, the economics training that I have about how governments step forward during these times to be able to provide care and support, it's a little bit different for labor and industries. We don't really know how this is all going to turn out, but just understand that our decisions are being made with a fiduciary mindset towards businesses and workers, and that's what drives a lot of us. We've got about 2,400 people right now who are working from home that weren't 3 weeks ago. So we continue to be operating at Labor and Industries. Our bills are continuing to be paid and processed, and we are still available to our customers. We have an FAQ on our website for people who have some questions, and we're dancing as fast as we can. Thanks, John. Thanks for giving me an opportunity to get this out there.
Yeah, great. Thanks, Ray. And I wanted to highlight the point that you made about interpreters. And we do need to make sure that they are integrated into telehealth, either by audio, calling them in, or sometimes there are video interpreters as well. That's a good point. Okay, thanks, Ray. So maybe what we'll do is go to the next presentation. And that's from Chris Cable, who's going to talk about what Kaiser Permanente is up to. Chris, do you want to take it away?
Chris, are you still on the line? I know you said that you would only be able to stay until 10:30.
No, yeah.
Is that you, Chris?
I don't see him on here. He has actually 4 slides, which, sorry to, I'm sure some of you noticed, especially Dr. Frank, that your slides changed when I changed them over into our file format. They got messed up a little bit. But if it's okay, I can send out these slides to everyone after the meeting.
So Nicole, that looks like the end of all the slides that we got. Do we want to check in with people who so wanted to share what they're doing, any challenges?
Yeah, sure. I did receive a couple of last minute slides, one from Joelle, so maybe we could start with her.
Sure. Hi, good morning. Can you hear me?
Yeah, go ahead, Joelle.
Great. Okay, a couple of things. Quickly, Chad was already on the call. As a clinician, I'm employed at Virginia Mason, and so I'm in one of the ambulatory general internal medicine clinics. And so obviously there's just been this rapid transition to telehealth. We're using the InTouch system there, and really just kind of scrambling to consolidate resources and deliver emergent care. My primary hat currently is working as a program director in our adult gerontology acute care nurse practitioner program at the University of Washington. And so there's been some work that was already really underway as a result of some HRSA funding, a grant that we have had for several years to develop nurse practitioners to work in rural settings, and obviously that includes telehealth. So, and then, concurrently with this crisis in our country, all of a sudden we are looking at the challenge of developing nurse practitioners from a clinical perspective without the benefit of supervised on-site, in-person, face-to-face clinical encounters with patients. So we've got a number of nurse practitioner programs, including public health, psych mental health, primary care, midwifery, pediatrics, and the program that I oversee, which is the acute care NPs, who are largely trained to work in the hospital and in acute care settings. So we're approaching our clinical training, at least temporarily, by simulation through artificial intelligence and virtual reality platforms for this evidence-based clinical training. And there's some really great solutions out there that we've been introduced to, including Oxford Medical Simulation and iHuman. The other thing that I've been working on is an end-to-end curriculum, training our nurse practitioners to work in the telehealth environment. And this curriculum takes about 6 to 8 hours to complete. It educates the nurse practitioner students in the regulatory practice and ethical standards of telehealth and the resources available to them when working in this space. This particular curriculum educates the nurse practitioners in behavioral health and addiction clinical care concepts. And then it really takes them through care delivery by telehealth in a formal simulation environment with a standardized patient. And this curriculum is going to be rolled out to all of the nurse practitioner programs that I mentioned, for the exception of the pediatrics. And it will include hiring, I'll be the primary faculty in this space, but we'll also be hiring drama students from upper campus to, I'll train them as standardized patients to function in this space. And from a formal simulation standpoint, we intended to roll this out in our simulation lab with the SP and the faculty and the student in various rooms, and recording them on a behavioral health platform called ClockTree. We'll be using Zoom since we can't all be in the same space. But Zoom also has a feature where you can record the visit, and we could use that in that simulation, replay and debriefing to help train the students in how that telehealth care delivery visit went.
Great, thanks, Joelle. Were there any slides that you wanted to share other than just this first one?
Oh, I'm sorry. Oh, am I designated as a presenter right now?
No, I think.
Apologies.
Nicole,
I think Nicole is. So the second slide in that deck. There you go.
Okay.
So I just went through that. I don't know if we're going to be sharing them, but feel free to share.
And this is great, Joelle. Is this a widely available or for all kinds of nurses and nurse practitioners, or is it just at the University of Washington?
Well, we had already planned to pilot it, so it was really ready to go. We're just wrapping up with our summative and formative evaluation processes. So this was really our go live time to pilot it, and obviously we're going to roll it out on a broader scale. And then, it'll be ready to roll out to anybody. And in fact, because it's funded by this HRSA grant, it will be available. There are actually a number of resources that we've developed in that telehealth space, including that telehealth module that I shared with you a few months ago, John. And it all lives in a certain place on the internet, but it's available to all. And this curriculum will also be available for use. So, we probably have a couple weeks of kind of ironing out the bugs and making sure it includes the patient script. It's really end to end and all bundled in formal simulation documents. So there are also other resources across the country. We are not the only new grantees. And there are other universities who have been working on similar stuff and have them housed in various places. So we'd be happy to collate that information and share it with the collaborative if people are interested.
Great, thanks, Joelle, and congratulations on all this exciting work. The integration with the Simulation Center I think will be really helpful. I'm wondering if I can check in with Danny Lorden and Kathleen Damon to kind of hear what Providence and Swedish are up to. Danny?
Here and ready, John. And let me go ahead and share what I've got here.
Great.
Host disabled participant screen sharing. Let's see, can you stop sharing, Nicole?
I did, but Zoom just changed how they do this, and
okay.
Here, you can also, Denny, if you want to email it to me really quick, then I can try sharing it.
Okay, I won't hold up the group here. I'll just go ahead and get started. Hi, folks that don't know me. I'm Denny Lorden, the Telehealth Partnering Manager for Providence St. Joseph Health. And my area of responsibility is for Eastern Washington, Idaho, and Montana. And my colleague, Kathleen Damon, is responsible for Swedish and Providence and Western Washington. So as Dr. Scott alluded to, we as well have partnered with Microsoft to build a chat bot. And our primary goal with that is to try and triage folks into the right direction of care. So probably the next level for us would be online virtual visits with our Express Care program. So I'd say about a month ago, we were seeing 50 to 100 Express Care visits a day, and now we are over 1,300 a day. So it's definitely picked up and folks are becoming familiar with that. So some of the other things that we're up to, and I guess I'll just start by saying, if you're not familiar with Providence St. Joseph Health, we're a very large health system operating in 8 states. And as you can imagine, if you've done telehealth for decades like we have, steering and slowing down that ship and changing direction is a monumental task. So we've kind of had to adjust the way we think to be able to deal in a timely manner with the situation. So we've kind of divided and conquered, and we're really focusing on 3 or 4 major different spaces. So the ambulatory space, acute, home monitoring, and then what you might call a hospital at home. And then we're also working on our behavioral health program for our own employees. So in the ambulatory side, we were very busy enabling 7,000 providers to be set up with Epic and Zoom doing virtual care visits. So mostly primary care and ambulatory care physicians that are now set up, and we wanted to make sure that they were well able to document in Epic the visits with the virtual visit crisis type, bill appropriately, and that's going very well. So now we're moving to outpatient hospital departments. So right now we're seeing over 5,000 visits a day on the ambulatory side. So that's going well. On the acute side, we're really trying to get ahead of this potential surge, and we're focusing on the different hotspots. So Seattle, California, Oregon, Eastern Washington, probably next. And we as well use the InTouch platform. So right now we're primarily focusing on setting up providers for the hospitalist space, the ICU, ED spaces. And so we have numerous providers there to get set up with licenses and brief training. Unfortunately, we don't have the ability to set up all the workflows that we normally would for a very structured process, but we're doing the best we can as fast as we can. So we're creating accounts for those as well. ED triage, we're also looking at using Zoom platforms on mobile devices so we can minimize traffic and PPE usage. And so probably the biggest challenge we're dealing with right now, I'd say, with a lot of this is that we're getting inundated with one-off requests. So as you can imagine, mental health professionals that work for the state or the county that now want to beam into the emergency room and assess patients, and hey, we have our own WebEx platform, we're ready to go with that. Well, sorry, that's not an approved platform that we can support. We're going to have to run that through DLA. And we get these all day long. And so it's really for us a matter of triaging these and prioritizing these. So we've set up basically 2 camps where we can do a quick project intake request for the acute side and one for the ambulatory side. We'll triage those rapidly and determine their priority and then try and address those as we can. We're also dealing with home monitoring program where patients that are not sick enough to be in the hospital can be monitored at home with a digital thermometer and a pulse oximeter. And right now we have over 700 patients of those that are enrolled and being monitored. So those are COVID patients and patients under investigation, and that's growing as well. The nice thing is in the first week of that program, we had some net provider scores of 100%. So it started well, and that kind of speaks to how folks are accepting the technology and being cared for at home and that sort of thing. And lastly, as everybody watches the news, you'll see the stress that's placed on our providers, nurses, and physicians. And we felt a need to grow our existing behavioral health concierge program. So that's mental health consults for our own caregivers. We want to stay ahead of that and make sure that they have a place to go to and have their needs addressed in a timely manner. And so we're growing that quite a bit right now. So I'll stop there, John, and see if there's any questions. Or Kathleen, do you have anything to chime in?
Yeah, let me add a little bit. I want to address the home monitoring. So with the home monitoring program, Denny mentioned that we have over 700 people currently enrolled in that. They're enrolled into the time period until they kind of graduate from it and don't have symptoms or are outside the 14-day window where they may not be contagious anymore. We quickly hired a bank of RNs to, a lot of them were misplaced or replaced staff that were on the inpatient units. So from the ORs, the PACUs, et cetera, have moved them up, and then they are taking in the data and assessing and then calling back the patients. The patients are actually submitting their vital signs 3 times a day, and then the nurses have oversight, and we enabled a program that prioritizes with a red, yellow, and green, and we have follow-up. Then they are calling those patients back, and then in some cases having them sent to the EDs. So not only are they just submitting their information, I think that's the challenge is making sure you stay on top of the data that comes in. The other piece is that we are rapidly expanding our tele-ICU program, and that's been going on at some of our sites since 2002. So trying to rapidly expand that to support the caregivers. For some of our caregivers, the providers, we are getting them access from home. So if they have been exposed and or tested positive but are unable to practice bedside, they can support from home. And also with our hospitalist program, the same thing. Several of our, a lot of our providers have been exposed and or have tested positive, but to be able to allow them to still support their colleagues, we've provided them with access from home, and I think that's been a huge asset. One last piece is that a lot of our different regions, as Denny said, we have sites all over the 8 states. A lot of regions have had their own programs that have been very successful. Swedish, for example, had a telehospitalist program, and it's a simplified workflow. So we are taking the simplified workflows and providing them to our partner hospitals so that they can use this and then quickly stand up a support mechanism. We're not dictating, and as Danny said, we can't really do the robust oversight in ensuring that we have provided a very tight workflow, but we are providing some of the basic templates so that folks can plug in their own numbers and not really dictating what they do, but we want to make sure that they're able to quickly stand up their program. So Danny, I don't know if that was too much.
And just sure, that's great. Thanks, Kathleen. And just to add a couple more things, like many of you, we use the InTouch platform, and to try and get ahead of the surge that we anticipate, we're in the process of building over 300 carts to distribute throughout the Providence system to be used where needed. And we know that not just intensivists and hospitalists are going to need access to these, but cardiologists and a lot of other specialists. There's also programs that were in discussion and early development, like telepalliative care, which all of a sudden have risen to more importance that we need to address because some of those folks can't be visited by families and need that level of care. And so there's a lot more programs that are being developed as we move this along.
That's great. Congratulations.
And I would say quickly fast track. There's a lot of fast tracking.
Yeah, Denny, I definitely resonate with the one-offs. You know, I tell them it's not Burger King. You can't have it your way, at least not now. Yeah. So we're going to try to move things along, and I want to call on Mark Lowe at Seattle Children's. Mark, I'm going to pull up your slides.
Well, thanks. Thanks, everyone. Just kind of going off Danny's comments. We're a much smaller shop, but just like all of you, we have just had tremendous change and growth in the last 2 to 3 weeks. The two main issues that, well, I'll say overarching, some of the things that we've had to struggle with have been just relaxation of our own internal sort of training modalities, et cetera. We can't do in-person training. We moved it all to virtual. We had a pretty robust privileging process for hospital privileges, but as the number of providers requesting those increased. We actually had to do a full relook at our privileging process, and that actually got changed to more of a training and not a full medical committee privileging process, which is really a big change for us since we've had that process in place for about 15, 20 years. The two main thrusts of what we've done for our COVID-19 response has been inpatient and home telemed. With inpatient, very similar to what everyone has been saying, we had the goals of trying to minimize provider exposure to strict respiratory isolation patients, as well as trying to conserve our dwindling PPE supply. And so we did that. We actually had no inpatient telehealth devices on main campus at Seattle Children's, and we have ramped up to 20 plus devices in short order. Again, full disclosure, I have no disclosures, but we use the InTouch platform as well for that, and it has scaled pretty rapidly and well for us. And so in some of our ICUs, they will just keep it on the entire time, and they use it as an augmented provider presence there. They find it very helpful. And then we've also used it for teleconsults. And it's sort of interesting in that it's not remote telemedicine. Oftentimes they are 5 feet away in a hallway or in a room around the corner, but it could just as well be virtual. And so we've had several of our specialties do consults that way, as well as ancillary staff like lactation services or social work, et cetera. And then we've also deployed, again, in an augmented fashion in resuscitation. So our emergency departments and ICUs, even though they're standing right outside and they can have visual inspection of everything that's going on, they can actually use telehealth to, the code leader stands outside actually now. And we've gotten it down to only 3 providers within the room for full resuscitation, including intubation. And so it's definitely changed the way that we do our business, but it is necessary because of, again, lack of PPE or just trying to minimize exposure. So we have a special infections unit that was created in our Ebola response, and now it's for COVID-19, and then those other areas as well. The second area has really been in our home telemedicine platform, and we have immense gratitude to John Scott and UW Telehealth for helping us along that. So the short story is that we had a platform that was nicely integrated to our Epic scheduling. It was working pretty well. And then with the surge in volume, as well as with the increase in bandwidth needs in the Pacific Northwest with everyone telecommuting, our platform didn't quite rise to the challenge, and we had a lot of disconnections to the point where we really had to pivot pretty hard to another platform. And so that was a tremendous amount of work, but within a week, we actually were able to sign, and we're starting to roll out what we can again. And similar to some other shops, home telemedicine was a pretty limited affair with a pretty strict intake process, a lot of oversight, et cetera. And just with this disaster response, it's kind of, the doors have been flung wide open. And so we're trying to get our arms around it and allowing individuals to provide their visits, as well as multidisciplinary, working on the different states which have relaxed the medical licensure requirements, and also trying to bring in video interpretation. So it's definitely been the fire hose, drinking from the fire hose approach, but we are grateful in that we're able to scale as best we can.
Great, thanks, Mark. I want to get to Jeff Jones, and then we'll open it up for comments and questions from the public. So Jeff, if you're able, I got your slides up. I'd love to hear what you're doing in Newport.
So again, Newport, we're a little different than a lot of places. We're a small rural area. We also have a fairly integrated health system, but we've got a lot of different things. It's not just hospital, not just clinic. We've got an assisted living, advanced care, as well as the hospital, clinic, ER. We were very aggressive early on in this. Pretty much just as soon as Seattle started doing things at the UW health system, we thought, well, we might as well do that too. So we started visitor restrictions and universal screenings really quickly. And then again, right with that is we rolled out telehealth. Right now, we've rolled that out. We scrounged up a bunch of cameras and microphones and have all of our providers here doing that out of clinic. Just clinic visits. We're not doing much in the ER or on acute care in the hospital with that. We are doing that into our assisted living to try to minimize folks going in and out of there. I think, again, we rolled out with the Doxy.me platform. It's fine. The interesting thing that I would like to bring up to this group is I think that there are some technological barriers to use in rural areas. You know, shoot, we're lucky if we have 3G coverage, let alone 4G or 5G is sure a nice myth out here. And there's limited cellular data plans for a lot of folks as we try to use that. Many people here certainly don't have Wi-Fi in their homes or a laptop even. That being said, a lot of people do. And I think the real challenge to telehealth in the rural areas is actually cultural. And it is not age related. You know, if you think it's the 70-year-olds that can't do telehealth, I'd tell you you're wrong from our experience over the last 2 weeks. And so it really varies based on the person, and you just have to kind of work with them and educate them on how to use that. So I'll stop.
Great, thanks, Jeff. That was interesting. The cultural, that's more important than age or things like that. Yeah. Well, great. So we have about 10 more minutes, and this is where we open it up for members of the public to ask questions or say something. So I'm going to stop sharing, and maybe I can start with Leslie Emmerich because she had a couple of questions. I'll turn over to you, Leslie, and just for everyone else, you can just briefly introduce yourself. Leslie?
Sure. My name is Leslie Emmerich. I'm the Public Policy Director for the Home Care Association of Washington, which has home health, home care, and hospice agencies. And I'm also the Policy Director for the Washington State Hospice and Palliative Care Organization. And one of the things that we have found to be a barrier is in the statute, RCW 48.43735, is the prohibition against using the audio-only telephone. And a lot of the examples that people gave today about serving low-income communities, especially in rural areas, you know, a lot of people can't afford dish, or they don't have, you know, smartphones and ways to address that. And what we've also found in home health is that if we have phone calls in between visits where we can collect the vital statistics like on the blood pressure and the weight and the oximetry, you don't need a smartphone to have that, you know, two-way communication to get that information. Yes, but yet it's vital health information to make a determination whether that person is medically stable, whether they need to, you know, have an RN or somebody, you know, go visit them. And I really like to suggest for the future work of the collaborative that we remove that barrier to audio-only telephone, because I think that actually is a barrier to care, and it discriminates against people in low-income, especially rural patients or people who can't afford these services. And I think you could make it, you know, specific to medical necessity or checking in on vital signs or something like that to put a little boundaries around it. But by prohibiting it, it definitely is a barrier to care. Thank you.
Thanks, Leslie. I wasn't aware of that barrier. And I know from the latest guidelines from Medicare that they're accepting phone also.
Yes, so this would be something we'd have to fix in statute, and it's in F and G of that statute under the definitions for store and forward technology and telemedicine. It says telemedicine does not include the use of audio-only telephone.
Okay.
That's what would
Leslie,
need to be.
maybe if we can follow you offline and connect you with Stafford and Samir to see how we can make that fix.
Great, thank you.
Thank you for pointing that out. Other questions or comments from the public? Yeah, while people are thinking, we'll make these slides available. Stephanie Cowan had some things from Multicare that she wanted to update, but she got pulled into another conversation. So I know that Multicare is offering these e-visits. So these are asynchronous visits. They made those free as well, and they've seen a massive increase on that, and that's been a great way to answer questions. So questions about how you can join the collaborative. This is public, and so people are free to join. It's not currently accepting new members, and that was by statute of the bill that created the collaborative. Nicole, do you see any other questions coming in through the chat that maybe people are shy to ask?
I'll keep an eye out. There's been a lot of discussion about the training of behavioral health providers. And I know that's, there's a lot to unpack there. But if there's any specific questions that, to the folks that brought up those issues, if there's any like specific questions that you think we could address to the group in the next minute or so, now would be the time to do so. But otherwise, both Sean and I will reach out to you and follow up on the sort of the larger, more philosophical questions.
All right, well, Nicole, do you just want to remind folks when our next meeting will be? I don't think we're going to be doing too many in-person meetings in the near future, but we've been trying to do these every 6 weeks. So Nicole, do you know, I think it's early May, right? And sorry to put you on.
Sorry, no, it's okay. I'm just gonna pull it up really quick. Let's see. Yeah, the next one is May 12th. And we'll see whether or not we actually get to meet at Providence. Yeah, so May 12th from 10 a.m. to 12 p.m. is the next one. And for folks that shared slides about the status of their organizations, are there any objections to sharing those slides with the group or potentially with a wider audience?
And please let us know if there's things you think would be beneficial for the public. We can post those on our website. I do want to make another plug for the NRTRC. That this is a great service that people are wanting to get into telemedicine. They don't know where to start. They do offer 10 hours of free consulting. They also have their annual conference coming up, and I think they changed that to a virtual conference. It'll be in about 2 or 3 weeks. We'll be posting the details on that. But I imagine there'll be lots of conversation about how to use telehealth in response to COVID at that conference as well.
There was one question that came up recently about, and John, tell me if this isn't the right venue for this. There's an issue with if providers are located at home, how they should document that. If there is apparently a change recently that if the provider is located at home, it needs to be modified with a PS212, or sorry, a POS 12 versus a POS 2. Is that something that you wanted to bring to the larger group?
Oh yeah, thanks for, yeah, and this might be something that I might ask Chris or Chris's billing experts on. Do you know, Chris, say I'm not in my office, but I'm at my physical home, say I'm on furlough or whatever, how we document that and what's the modifier?
I think we have been encouraging providers to just document what the originating distance site is in their notes themselves, and then point of service specifically for traditional telemedicine vehicles has been POS02 for telemedicine, and then for like more telehealth stuff has been where the patient is located rather than the provider. But Jody, did I get that right?
Yes, this is Jody. That's the way we've set it up, because when we were reading CMS's guidance prior to what they just recently put out, place of service is where the client receives the care.
I see. Okay, so if you're at home, you should use a POS 12, is that right?
If the provider is at home,
yeah.
we don't, it doesn't matter. It's where the client is. Does that make sense?
Yeah, okay. And Cheryl, you're nodding your head too.
Yeah, so it should be a place of service too.
POS 2, okay. Okay, thank you. Thanks for clarifying that.
Thank you.
Okay. Nicole, anything else we need to loop back on?
No, I think we're good. Yeah, thank you all for being so adaptable to the Zoom format.
Okay, great.
Thanks for all your coordination.
Yeah, thanks. Take care, everyone. Good luck.
Thanks, John.
Stay safe.